Dan procedure as a daycare, of course, kita ada juga yang gynae punya orthopedic procedure, gynae orthopedic procedure, but I take 4 major discipline: pediatric surgery, pediatric ophthalmology, pediatric dental, and pediatric ENT. These are the list of our most common procedure done in a daycare setup. Same as the adult, to select patient that suitable for daycare, we have some guidelines and criteria. Guideline we can divide into patient criteria, surgical criteria, and social criteria. So kita ambil daripada standard operating procedure for the daycare procedure. So for patient criteria, biasanya anda akan tengok ni patient LT ASA1, ASA2. ASA3 ni kita kena tengok whether dia control, nak macam katalah dia ada asma, whether dia kena tengok, itu nanti the pre-med akan consider lah whether this control or not. In general kita ambil ASA1, ASA2. Age they accept age 6 months and above, but this one depends on the local setting, depends on your local setting. Kalau dekat HSNZ kita accept berapa 8, 10 bulan atau setahun, depends on consensus between the surgeon and anesthetic, which one dia familiar to handle the babies, right? So in general actually 6 months is already good enough provided the child is term. If the child premature, so kita akan take as corrected age 60 weeks, 60 week corrected age, because kalau below 60 week corrected age, dia akan dapat apa? Easy dapat apnea kan, ada risk for apnea post-op, and no obvious difficult airway deformity like macam katalah dia tak adalah sindrom sangat, tapi muka dia tu macam ada soft syndromic features, small chin ke apa semua tu, tu macam boleh anticipate of difficult intubation of airways, so it's not suitable. And also kalau you perasan anak-anak sekarang ni pun dah mula obesity apa semua kan, tu relatively contraindicated jugalah, walaupun tadi ada kata difficult intubation, difficult airway management tu, obesity ni is a bit sikit kan, boleh manage, but the person yang anesthetic tu yang nak underkan child tu a bit concerned about the obesity. So in general we don't take more than 35 BMI. In surgeon perspective, the surgery is simple, is less than 90 minutes, but kalau you tengok procedure yang list procedure tadi tu kan, semua yang sekejap je sebenarnya. Kalau you pernah involve in pediatric cases, kita buat pun sekejap je. Kalau I punya OT tu memang sekejap je lah. Terkadang nak underkan patient, nak prepare patient tu bit lama sikit kalau compare dengan procedure tu. So most of the procedure tu is suitable for the daycare criteria, and minimal risk of post-op complication, especially bleeding, infection, and minimal post-op pain, and not required specific nursing care. But for my cases, my OT, if the child required CBD insertion post-op, katalah kita ada buat surgery for modified circumcision with the penile, so kita nak prevent dia from the edema, so we insert the CBD, we let the CBD for 24 to 48 hours. We just explain to the child, the CBD we keep, you just tak perlu apa-apa, make sure dia tak tarik ke apa semua, then after 48 hours you can remove the CBD at your nearest clinic. So that not require a special nursing. So the surgery also would not have a prolonged immobility, and the surgery must have rapid return of normal food or fluid intake. Maknanya dia soon after dia recover from GA, usually kita dah boleh dah kasih dia fluid, sebab biasanya dia ni fasting from 2 AM. Lepas tu dia dah was gassed down, so by the time dia bangun actually dia crying trying dia lapar, pun tak sure dia ni lapar sakit ke, lapar makan ke, menangis sebab sakit ke, menangis sebab makan ke. So make sure yang kita punya surgery itu not prevent dia daripada take orally. For social criteria, first because tadi kan kita kata importance element in daycare surgery ni adalah parents involvement. So yang parents factor is very important. So parents kena willing to cooperate untuk daycare surgery ni. Alright. Number 2, escort. Kalau adult, seorang je tak apa. Dia pergi, dia seorang escort je untuk dia balik tu tak apa. Tapi kalau pediatric, dia kena ada dua lah. Whether husband and wife, maknanya father and mother, ataupun ada seorang lagi caretaker. Sebab seorang kena drive, seorang kena jaga dia anak dia kat belakang. Alright. So tak boleh mak datang, bapak kerja. So nanti mak kena drive kereta, anak kat belakang nak kena jaga, siapa nak jaga. So kita make sure masa kita explain dengan parents tu, parents ada seorang another person untuk datang on the day. And make sure you ask for transport. Do not advise the patient or parents to take public transport, or kalau dia ada motor ke, you kena explain lah. Is very dangerous untuk bawa balik dengan motorcycle. And the distance kat rumah dia dengan hospital or any nearest health facility is not more than 1 hour. Last time kita kata distance tu dengan kita, kalau patient tu dekat Marang, jauh-jauh sikit dengan HSNZ tu, kita dah rasa dia not eligible to do a daycare. But kalau dia ada nearest hospital, nearest healthcare facility yang dia boleh pergi dulu, kalau dia kata ada apa problem, complication, dia boleh pergi and seek first treatment, then we accept. And they need telephone access lah, sebab kita nanti kita nak contact dia dulu to confirm the surgery, then after that kita nak kasih dia follow up appointment semua. So walaupun patient ni memang excellent candidate untuk daycare, but we face few challenges in managing children in daycare OT. First is everybody agree the high cancellation rate in children because of URTI. Anak-anak ni memang senang dapat URTI compare dengan kita. Kenapa? Because the immune system is not mature. Faham yang ni quite straightforward. And they easy dapat URTI because diorang ni selalu overcrowd. Dia kalau main-main ataupun kita hantar dekat nursery, one infected URTI, semua URTI. And then ataupun dia main kat playground petang-petang, seorang batuk semua, kita call dia, actually kita call to confirm whether dia healthy or not for the next week elective list. Tapi the day before that dia pergi main, pagi tu dah batuk sesama. So dia easily dapat infection URTI lah. Because of kenapa dia senang dapat URTI, dia kurang exposure. Kalau kita dah besar ni, kita dah immune, kita tahu badan kita dah immune because kita selalu dah dapat infection. So kalau untuk pediatric ni tak. And dia close contact dengan caregiver, maknanya dia dengan parents bit ada running nose, dia easily lah dapat. Compared to kita yang adult ni, kita not really close contact sangat dengan orang sekeliling. And also dia weaker hygiene practice budak-budak kan. And the airway also anatomically dia underdeveloped to protect the source of infection. So we see the data, kita tengok pula kan tadi kita kata high cancellation rate kan. So nak tengok, let's the numbers, see the this one for HSNZ. I get the data from the Perkhidmatan Rawatan Harian for 2022. Kita tengok the incidence of cancellation, the reason fever and URTI. Dan main contributor dia adalah pediatric patient. Yang lain-lain tu macam reason tu because of adult punya reason lah, right? So this one lah, kadang-kadang kita katalah in my OT kita target 5 patient. The 1 week before kita dah call, tanya semua everybody sihat, kita dah follow up dia semua sihat. On the day, dia call balik tak datang, ada batuk sebab because of ni dah wasted our OT slot. The other issue is fear and anxiety. Budak dia ada social anxiety towards the stranger. That's why very important to get rapport to the pediatric patient. By the time dia nampak you je, dia dah jumpa dah kat klinik, dia dah tahu dah dia kena examine. So this one dia dah macam suspend. So dia a bit susah you nak tackle budak-budak macam ni. Jadi you need for the pediatric doktor ni, doktor yang handle budak-budak ni, dia ada skill. Usually dia akan develop a skill how to handle children, how to get the rapport, macam mana nak dapatkan dia punya trust towards you before you can touch them. And children also have we have difficult in communication, especially in younger children. Kita nak explain, oh you nak kena buat surgery ni, after this jangan pull out all the tu katalah kita perlukan CBD ni kan. Salah communication sebab budak kecil kan. So it's a bit challenge to us. So yang pentingnya kita explain to the parents lah, right? Nanti parents tu pandai-pandai lah dia kena jaga anak dia. Yang penting parents tu kena dapatkan cooperation parents. Sometimes parents, kita dah explain, kita did a good job explain to the parents. The patient okay, budak tu okay je, relax je. Tiba on the day of surgery, parents pula breakdown emotion. Dia pula nangis lebih. Budak tu dah nak masuk, tiba-tiba bila dah nangis. Yelah kita nak tidur, dia nak underkan dia. So dia takutlah lepas ni tak bangun ke apa, dia nangis. So dah menyebabkan anxiety pula pada anak dia, kena mak dia dah menangis. Tu antara isu sebenarnya. You bukan handle the patient saja, you kena handle the parents pula. Kita nak harapkan parents untuk comfort the patient, jadi kita kena comfort parents pula. Right? And pain management, I think I will touch more because Dr. Habib, our pediatric anesthetic, akan explain about pain management in pediatric daycare surgery. And even though we select the cases that have lower risk for complication, but bear in mind the complication still happens. So that you need to very vigilant doing the surgery, even though it's a bread and butter. Sometimes you kata kalau macam lidah you punya pejam mata pun boleh buat, tapi anything can happen. And last but not least is limited resources. What means by limited resources? In general, sebenarnya kita biasalah under staff, under facility semua kan. So sekarang ni facility dah ada, staff ada walaupun tak cukup, tapi we can still manage to make daycare surgery ni successful. Alright, for the children particularly, resources yang perlu adalah the specialty. Tak semua katalah surgeon, sebab tu dia ada subspecialty dia, katalah ENT, dia ada subspecialty pediatric ENT, dental pun ada tu, surgical pun ada pediatric surgeon, optal pun ada pediatric optal. So the resources tu very limited, especially yang subspecialty ni. Mungkin pediatric optal dia cover East Coast, Terengganu je ada piece optal. So the workload tu very high untuk dia load, right? So you kena develop the subspecialty for the children. But beside all the challenges yang banyak sampai 7 challenges kita tu, still kita masih lagi boleh, masih lagi feasible untuk buat surgery on the children as a daycare. Because satu, kita kena acknowledge our friend anesthesia factor. So anesthesia ni dia dah more advanced, dia dah ada subspecialty dah. Kita ada dah pediatric dekat Terengganu ni ada seorang je, dia lah seorang yang pediatric NS kat sini. Tapi dengan adanya subspecialty ni menyebabkan kita lagi boleh banyak lagi kita buat case, even though nampak a bit complicated the case, tapi because of dia dah subspecialty in pediatric, so kita boleh improve. Point of view, tadi I cakap kita ada develop advancement in surgical technique like minimally invasive, ada subspecialty for pediatric. So kalau before this mungkin tak banyak sangat cases done in the daycare because was done by general. So kalau bukan nak cakap adult surgery, tapi dia akan lebih cautious. So dia tak apalah, kita monitor dulu post-op as a inpatient. Tapi kalau yang dah ada subspecialty ni, lepas tu dia punya bread and butter, so dia boleh predict this one should be okay to discharge. Next one, pain management. We have established multimodal pain management guideline for the pediatric daycare. And nowadays actually education to the parents pun more educated, more easy untuk kita explain because dia pun ramai cikgu, ramai yang actually dah boleh faham sebenarnya surgery macam mana. Sometimes ada yang explain the procedure pun before dia datang kat you, dia dah Google dah siap. Even dia sendiri dah cakap dah, tak payah admit kan, macam tu. So you have the advanced parents nowadays, so easy actually for you to explain and get their cooperation. Last but not least, it is facility and equipment. Ideally, satu, daycare dia boleh stand alone building, dia stand alone dia punya unit daycare surgery. For the pediatric population, kita tak adalah nak buat satu another tempat untuk pediatric, but in HSNZ, because I kerja kat sini, so I kena promote sikit lah kita punya ACC kita. Kita ada corner for pediatric corner ni. This one I was under initiative of the staff and doctor in daycare. Dia create one corner that very convenient, very macam nampak kan budak-budak pun nak datang sini happy. Kalau if you see this corner, ada 3 mak menunggu kat situ. Dia bukan untuk dia bukan saja untuk patient, untuk parents juga. So 3 mak tengah menunggu means 3 OTP tengah running daycare. So yang kat situ tu banyak toys was contributed by the staff. Anak-anak dia dah besar-besar sikit, dia contribute the toys kat situ. So anak pun macam happy. Dia datang hospital, hospital child friendly ke ni? Dah lah pain free, child friendly pula tu. Tengok, kalau adik ni dia sebenarnya dia tak tahu pun selepas ni dia nak kena potong dah tu. Tapi dia still distracted with the toys. Dia happy, dia tak nangis. So ada satu yang sorry. Okay, actually ni ada video showing this child. Dan kita dah nak guess down dah dia. Kalau you tengok from the picture tu, the patient ni even dia use dia punya baju tidur, tak tahu dah dia dah mandi ke tak, tapi generally we ask the mother to early morning tu bath dulu. So tapi dia dengan baju tidur datang, no lunch, dia just fasting at 2 AM, pagi tu no breakfast. Dia Dia datang, tak ada line, dia datang di situ, dia happy, dia macam excited nak naik atas GA table tu. Right? Mother pun duduk kat situ, tapi mother kena tukar baju lah, kita nak reduce risk of infection semua. So kita just allow patient no need to change their clothes. Alright, a bit about our data in daycare HSNZ. This one is entrance, nampak besar tapi sebenarnya dia kecil je because I dah ni karik dia nampak besar pula, memang grand entrance pula. Okay, this one we analyze the pediatric cases done by pediatric surgery, speech optal, speech dental and speech ENT. So surprisingly memang even speech ENT tu also done a lot of cases as a daycare. Kalau pediatric surgery ni memanglah kan. So tapi speech optal, speech dental, this one 2019 pre-COVID dan 2022 kita come back, tapi dia akan slow naik lah, dia turun sikit. When we talk about daycare, bila kita analyse or audit daycare, kita ada kena satu indicator. So satu indicator dia kita monitor the daycare rate. Daycare, true daycare lah, true daycare. Because sometimes daycare, you punya daycare facility tu you combine dengan inpatient, you combine dengan emergency kan. But we only take the true daycare surgery. So bila kita compare daycare surgery rate ni untuk pediatric and general, tengok kalau pediatric almost semua more than 30% for the last year. Before that, before COVID tu lagi tinggi sebenarnya. So then COVID dia menjunam sikit, then 2020 kita recover, but in general, surgery, speech dental, even OR also, our daycare rate is more than 30%. But kalau dah in for the hospital, kita dah diluted dengan adult, so total daycare rate HSNZ is 28%. What's the importance of daycare rate ni? Because daycare service is part of component of pain-free hospital. Untuk menjayakan pain-free hospital ni, you kena jayakan daycare service. So daycare rate ni, dia dapat formula dia, numbers of daycare surgery dan divide by total number of inpatient dengan outpatient sekali. So you dapatlah the percentage. So untuk kriteria untuk pain-free hospital ni, dia kena, kalau aim tu more than 20% lah. Tapi kalau you nak achieve, dia dapatlah score. Dia ada the score ni. Ini based on the latest guideline of pain-free hospital. So kalau you achieve more than 20%, you dapat maximum score. Okay, this a my few last slides. I just want to show the national data for daycare service in pediatric surgery across the nation. Not all, for your information, not all the state have standalone daycare service, and some center just started the pediatric surgical service. So about the same, dia punya before the era of COVID, there is quite high number, but you see 2022 not all center recover from the COVID. Maksudnya dia tak dapat lagi daycare standalone daycare service diorang. Sebab diorang dah, dia punya daycare OT, daycare ward tu telah di-convert dah jadi benda lain lah. Sekarang dah tak ada COVID dah, dia belum dapat lagi hak bilik diorang tu. So ada certain center macam HSNZ 2022 kita dah open up our daycare dah. Kita dah clear up our backlog. Tapi ada certain state yang masih tak boleh lagi, but they have choice to do as a outsource ke apa lah. Okay, this this is my reference. Sebenarnya I pun baru kata masa nak buat slide ni. This kalau you nak master in the daycare, ni you kena katam this module lah, manual this one. Okay, last slide, don't worry, boleh bunyikan loceng. Kalau kita nakkan kita our daycare service ni cemerlang, terbilang dan terbilang ni, always you kena emphasize dengan you punya MO. That's why this symposium all about, because you nak increase the awareness. Every time you want to book patient for elective cases, always in your mind, why cannot daycare? Mesti dia kena daycare until contraindicated. Alright? Even in specialist, macam I buat round pun tengok, patient ni masuk ward oh dia duduk jauh-jauh ataupun dia tak ada transport apa so that one kita acceptable. Dia mesti ada reason kenapa dia berada di ward, because all this dia kata dia sangat bagus candidate untuk buat daycare. Alright, because all the advantage yang kita bagi tahu tadi tu kan, so for advantage for the parents and for kita healthcare kan. Alright, so take home patient almost always tanya why cannot daycare. Kalau boleh itu ada inisiatif daripada, I tengok kalau general surgery tu dekat buku elektif tu dah chalk dah, why not daycare, kalau merah lagi chalk. Sebab you kena ada reason kenapa tak boleh. Kalau my OT tu kita ada tulis remark dekat elektif, OT list kata kena ada remarks tu. Kalau tak orang tu kena panggil, kenapa book patient ni kat elektif. So dia pun masa tu pun terlupa kenapa so dia buat remarks dekat situ, kenapa patient ni kena admit. Alright, that's you can dengan cara tu you boleh utilize your daycare slot. Alright, with that, thank you.